Summary of cyanotic heart defects, CHDs. Characteristic symptoms and pathophysiology. CHDs involve abnormal connections in the heart leading to right-to-left shunting, causing deoxygenated blood to enter systemic circulation, resulting in cyanosis. Symptoms include cyanosis, failure to thrive, heart murmurs, and signs of heart failure. Common causes include genetic factors, maternal conditions, and environmental influences. Clinical presentation and diagnosis. Diagnosis relies on echocardiography to visualize defects, supplemented by findings such as low oxygen saturation and characteristic X-ray signs. Common CHDs include Tetralogy of Fallot, Transposition of the great arteries, and Hypoplastic Left Heart Syndrome, each with distinct diagnostic features. Tetralogy of Fallot, RV obstruction, RVH, VSD, and overriding aorta. Presents with TET spells and a boot-shaped heart on X-ray. Transposition of the great arteries, TGA. Aorta and pulmonary artery are reversed, requiring arterial switch surgery. Presents with egg-on-string appearance on X-ray. Hypoplastic Left Heart Syndrome, HLHS. Underdevelopment of left heart structures, treated with staged surgeries or transplantation. Treatment. Treatment varies by defect, but generally involves surgical repair or palliation and supportive medical therapy for heart failure. Tetralogy of Fallot, surgical repair involves correcting VSD and relieving RV obstruction. TGA, arterial switch procedure, is standard. HLHS requires staged surgeries, Norwood, Glenn, Fontan procedures, or heart transplantation. Prognosis. Prognosis varies. Untreated, many CHDs are fatal in infancy. Surgical interventions have improved outcomes significantly with variable long-term survival rates. High yield points for exam. TET spells, sudden episodes of cyanosis and tetralogy of Fallot, managed acutely by knee-to-chest positioning and oxygen. Egg-on-string X-ray, classic sign of transposition of the great arteries. Staged surgeries for HLHS, remember the sequence, Norwood, Glenn, Fontaine. Ductal dependence. Some CHDs require a patent ductus arteriosus for survival. Prostaglandin E1 is used to keep the ductus open preoperatively. Differential diagnosis table. Condition, key diagnostic signs, treatment approach, arterioplastic left heart syndrome, tetralogy of Fallot, boot-shaped heart, TET spells, surgical repair, transposition of great arteries, egg-on-string appearance, cyanosis, arterial switch surgery, hypoplastic left heart syndrome, underdeveloped left heart structures, stage surgeries or transplantation. Understanding the specific diagnostic signs, pathophysiology, and treatment approaches for each CHD is crucial for clinical decision-making and patient management. Clinical case, Tetralogy of Fallot. Patient information, age 4 months old, gender male, medical history, unremarkable prenatal history, full-term delivery. Presenting complaint, the parents report episodes of sudden cyanosis, especially during feeding or crying. They also mention that the infant seems to get tired more quickly than expected during feedings. Clinical examination, general appearance. The infant appears mildly cyanotic at rest, which intensifies during episodes of crying. Vital signs, HR 145 BPM, RR 45 min, SpO2 88% on room air. Cardiovascular examination, a systolic ejection murmur is heard at the left upper sternal border. The pulse is full and bounding. There is no clubbing or edema. Diagnostic workup, echocardiography confirms the presence of the 4 classic components of tetralogy of Fallot, VSD, overriding aorta, pulmonary stenosis, and right ventricular hypertrophy. Chest X-ray reveals a boot-shaped heart due to right ventricular hypertrophy and upturned cardiac apex. Pulse oximetry shows decreased oxygen saturation, SpO2 88%. Clinical course, during the examination, the infant experiences a TET spell characterized by acute worsening of cyanosis and irritability. The infant is placed in a knee-to-chest position and supplemental oxygen is administered, which provides temporary relief. Management plan, acute management of TET spells. The infant is administered oxygen and kept calm to reduce the severity of the spells. Intramuscular morphine is given for severe spells. Prostaglandin E1 infusion, initiated to maintain ductal patency and improve pulmonary blood flow until surgery can be performed. Surgical consultation, arranged for corrective surgery, which includes patch closure of the VSD, resection of the infundibular stenosis, and relief of the RVAT obstruction. Discussion. This case illustrates a typical presentation of Tetralogy of Fallot in an infant, marked by TET spells and a classic murmur. Echocardiography and chest X-ray are key in confirming the diagnosis. Early surgical intervention is crucial for improving outcomes and preventing long-term complications. Oral exam questions and answers on Tetralogy of Fallot. Question 1, Q. Describe the pathophysiological components of Tetralogy of Fallot and their impact on cardiac function. Tetralogy of Fallot consists of 4 cardiac abnormalities: pulmonary stenosis, which leads to obstructed blood flow to the lungs; right ventricular hypertrophy, a compensatory response to the increased workload on the right ventricle; a ventricular septal defect, VSD, allowing blood to mix between the ventricles; and an overriding aorta, which receives blood from both ventricles. Together, these defects result in decreased pulmonary blood flow and mixing of oxygenated and deoxygenated blood, causing cyanosis and reduced oxygen delivery to the body. Question 2. What are TET spells and how are they managed? TET spells are acute episodes of cyanosis and hyperpnea in children with Tetralogy of Fallot, triggered by activities that increase oxygen demand or decrease systemic vascular resistance, like crying or exertion. They are managed by placing the child in a knee-to-chest position to increase systemic vascular resistance, administering supplemental oxygen, and using morphine to alleviate distress and reduce ventilatory demand. Beta blockers may be used to reduce contractility and improve the dynamic obstruction at the right ventricular outflow tract. Question 3. How is Tetralogy of Fallot definitively diagnosed? The definitive diagnosis of Tetralogy of Fallot is made using echocardiography, which visualizes the 4 key features of the condition: VSD, pulmonary stenosis, right ventricular hypertrophy, and the overriding aorta. Additionally, a chest X-ray showing a boot-shaped heart due to right ventricular hypertrophy and echocardiographic findings support the diagnosis. Question 4. What is the role of surgery in the management of Tetralogy of Fallot? A. Surgical repair is the mainstay of treatment for Tetralogy of Fallot and usually involves patch closure of the VSD, resection of the obstructive muscle bundles in the right ventricular outflow tract, and repair of the pulmonary valve stenosis if present. This corrective surgery is typically performed in the first year of life to prevent long-term complications and improve survival. Question 5. Explain the significance of prostaglandin E1 infusion in the management of Tetralogy of Fallot. A. Prostaglandin E1 infusion is used in the immediate postnatal period to keep the ductus arteriosus open in infants with Tetralogy of Fallot, particularly those with severe cyanosis or TET spells. This temporary measure ensures adequate pulmonary blood flow and systemic oxygenation until definitive surgical repair can be undertaken. Summary of Tetralogy of Fallot. Overview. Tetralogy of Fallot is characterized by 4 key cardiac defects: pulmonary stenosis, right ventricular hypertrophy, a ventricular septal defect, VSD, and an overriding aorta. It's the most prevalent cyanotic congenital heart defect, with a sporadic occurrence but associations with genetic conditions like DiGeorge and Down syndrome. Epidemiology. Occurs in approximately 4 to 5 out of every 10,000 live births in the U.S. Pathophysiology. The condition arises from abnormal development of the infundibular septum, leading to a misaligned VSD and subsequent right ventricular outflow tract obstruction, RVOTO. The degree of RVOTO determines blood flow, affecting the severity of cyanosis and the mixing of oxygenated and deoxygenated blood. Clinical presentation. Symptoms range from mild to severe cyanosis, influenced by RVO severity. Severe cases may present with TET spells, acute hypercyanotic episodes triggered by stress or exertion. Cardiac examination may reveal a harsh systolic ejection murmur, a single S2, and signs of right ventricular heave. Diagnostics: prenatal echocardiography often identifies TUF before birth. Postnatally, echocardiography confirms the diagnosis by visualizing the defect components. Chest X-ray may show a boot-shaped heart due to RVH. The ECG might show right axis deviation and signs of right atrial enlargement. Treatment: prostaglandin E1 infusion is used preoperatively to maintain ductal patency in severe RVO cases. Management of TET spells includes oxygen administration, positioning, and possibly pharmacological intervention. Surgical repair, usually within the first year of life, involves VSD patch closure and RVO toe enlargement. Palliative shunts may be used when early surgery isn't feasible. Follow-up care is crucial to monitor for complications like heart failure and arrhythmias. Prognosis: without surgical intervention, the prognosis is poor, with a significant mortality rate in early childhood. With corrective surgery, the long-term survival rate significantly improves, with most patients living beyond 25 years of age. This summary provides a comprehensive overview of TUF, highlighting the importance of early diagnosis and surgical intervention in managing this complex congenital heart defect. Clinical case: Tetralogy of Fallot, TEOF. Patient profile: age 6 months, gender male, medical history, no significant prenatal history, normal birth, delayed milestones. The parents report episodes of the baby turning blue during feeding and crying. History of present illness: the infant has been increasingly irritable over the past month, with episodes of cyanosis, especially during feeding or crying. These episodes last a few minutes and are sometimes alleviated when the baby assumes a squat-like position. Physical examination: general. The infant is small for his age, with a noticeable blue tinge around the lips and fingertips. Cardiovascular: a loud systolic murmur is heard at the left upper sternal border. A palpable thrill is present. The pulses are full, and there's no peripheral edema. Respiratory: lungs are clear to auscultation bilaterally, with no signs of respiratory distress at rest. Abdomen: soft, non-tender, no hepatomegaly noted. Diagnostic findings: pulse oximetry shows an oxygen saturation of 88% on room air. ECG: right axis deviation, right atrial enlargement, and signs of right ventricular hypertrophy. Chest X-ray: a boot-shaped heart is noted, indicative of right ventricular hypertrophy and a decreased pulmonary artery segment. Echocardiography confirms the presence of a large VSD, overriding aorta, pulmonary stenosis, and right ventricular hypertrophy consistent with TOF. Clinical course: the child was admitted for observation and management of cyanotic spells. IV prostaglandin E1 was started to maintain ductal patency, and beta blockers were administered to manage the episodes. The pediatric cardiology team was consulted, and surgery was recommended. The infant underwent successful total surgical repair of TOF, including patch closure of the VSD and relief of the RVO, ODO. The postoperative course was uneventful, and the child showed significant improvement in symptoms. Oxygen saturation levels normalized, and the heart murmur was markedly reduced. Follow-up. The infant was discharged with a follow-up scheduled in the pediatric cardiology clinic. He will require lifelong monitoring for potential complications such as residual outflow tract obstruction, arrhythmias, or ventricular dysfunction, but the prognosis post-surgery is optimistic. This clinical case exemplifies a typical presentation of TOF in infancy, highlighting the critical nature of early detection, management of cyanotic spells, and the role of surgical intervention in improving outcomes. Oral exam questions and answers on Tetralogy of Fallot. Question 1, Q. Describe the 4 anatomical defects present in Tetralogy of Fallot. A tetralogy of Fallot consists of 4 key anatomical defects. 1. Pulmonary stenosis, which is an obstruction of the right ventricular outflow tract. 2. Right ventricular hypertrophy, which is thickening of the right ventricle walls. 3. Ventricular septal defect, VSD, which is a hole between the right and left ventricles. And 4. Overriding aorta, where the aorta is positioned above the VSD and receives blood from both ventricles. Question 2. What are TET spells and how are they managed? A. TET spells are hypercyanotic episodes seen in THOF, often precipitated by crying, feeding, or any activity that increases the body's oxygen demand. They are managed by calming the child, bringing knees to the chest to increase systemic vascular resistance, SVR, administering oxygen, and using medications like morphine to reduce the stress response. Beta blockers may be used to decrease the heart rate and improve ventricular filling. In severe cases, IV fluids and vasopressors might be needed. Question 3. Q. How is the diagnosis of Tetralogy of Fallot confirmed? A. The diagnosis of TOF is primarily confirmed through echocardiography, which visualizes the anatomical defects. Supporting diagnostics include a chest X-ray, which may show a boot-shaped heart due to right ventricular hypertrophy, and an ECG showing right axis deviation and signs of right ventricular hypertrophy. Question 4. Q. What is the definitive treatment for Tetralogy of Fallot? A. The definitive treatment for TOF is surgical correction, typically performed in infancy. The surgery involves patch closure of the VSD to direct left ventricular output into the aorta, relief of the right ventricular outflow tract obstruction, RVOTO, to improve pulmonary blood flow, and repair or replacement of the pulmonary valve if necessary. Question 5. What is the long-term outlook for a patient with Tetralogy of Fallot after surgical repair? A. The long-term outlook for patients with TOF who have undergone surgical repair is generally good, with over 90% survival into adulthood. However, these patients require lifelong cardiac monitoring for potential complications such as residual or recurrent outflow tract obstruction, arrhythmias, pulmonary regurgitation, and right ventricular dysfunction. Regular follow-up with a cardiologist specialized in congenital heart disease is essential. Summary of Transposition of the Great Vessels, TGV, for specialist pediatric doctors. Definition and epidemiology. TGV involves an anatomical reversal of the aorta and pulmonary artery. Represents approximately 20% of all cyanotic congenital heart disease, CHD, cases, with a prevalence of 2 to 4 per 10,000 live births in the U.S. Etiology, often multifactorial, associated with maternal diabetes and seen in about 1% of patients with DiGeorge syndrome. Pathophysiology, due to failed spiraling of the aorticopulmonary septum, leading to the right ventricle, RV, emptying into the aorta, and the left ventricle, LV, into the pulmonary artery. This results in complete isolation of pulmonary and systemic circuits, necessitating mixing through intracardiac shunts, e.g. VSD, ASD, or extracardiac connections, e.g. PDA, for survival. Clinical findings. Newborns present with postnatal cyanosis unaffected by oxygen supplementation and tachypnea. Cardiac examination typically reveals a single loud S2 and diminished femoral pulses. The presence of a concurrent VSD might produce a systolic murmur at the left sternal border. Diagnostics. Echocardiography is the confirmatory test, showing the pulmonary artery arising from the LV and the aorta from the RV. Chest X-ray may show an egg on a string appearance due to an enlarged globular heart and narrow superior mediastinum. ECG and pulse oximetry usually show normal patterns and decreased oxygen saturation, respectively. Treatment, initial management, initiation of mixing between the circulations is critical, achieved by PGE1 infusion to keep the PDA open and potentially balloon atrial septostomy to enhance atrial mixing. Surgical repair. The arterial switch procedure is recommended within the first 2 weeks of life, involving the reversal of the aorta and pulmonary artery and correction of any coronary artery anomalies. The Rastelli procedure may be indicated for TGV with concurrent large VSD and LV outflow tract obstruction. Prognosis: untreated, 90% mortality in the first year. With appropriate surgical intervention, long-term survival rates extend beyond 15 to 20 years, approximating 90%. Specific diagnostic findings: echocardiography, reversal of great vessels, possible presence of VSD, ASD, chest X-ray, egg on a string appearance, increased pulmonary vascular markings, pulse oximetry, decreased SpO2. Treatment details: pharmacological, PGE1 infusion, e.g. alprostatal. Surgical, arterial switch procedure, Rastelli procedure for specific cases. Supportive, oxygen therapy to create possibly inotropic support pre-surgically. High yield points. Immediate prostaglandin infusion post-birth is critical to maintain ductal patency. The arterial switch procedure, ideally performed within the first 2 weeks of life, is the gold standard for surgical correction. Long-term cardiac follow-up is essential due to the risk of postoperative complications and the need for potential reinterventions. A 3-day-old newborn boy presents to the pediatric emergency department with his parents, who are concerned about his increasing bluish discoloration, especially noticeable around the lips and fingertips. They also report that he becomes particularly blue and breathless during feeds. The mother mentions that her pregnancy was complicated by gestational diabetes, which was managed with dietary modifications. History: gestational diabetes during pregnancy. The baby was born at term via spontaneous vaginal delivery with no immediate postnatal complications. The parents first noticed mild cyanosis shortly after birth, which has progressively worsened, especially during feeding or crying. Physical examination. Vital signs: HR 148 BPM, RR 60 breaths min, SpO2 85% on room air, temperature 98.6 degrees Fahrenheit. General appearance: mildly tachypneic, significant central cyanosis noted around the lips, oral mucosa, and extremities. Cardiac examination: normal heart rate with a single loud S2, no additional murmurs or abnormal heart sounds detected. Pulses: diminished femoral pulses compared to brachial pulses. Respiratory: mild subcostal retractions with no added sounds on auscultation. Diagnostics: pulse oximetry revealed an SpO2 of 85% on room air, which did not significantly improve with supplemental oxygen. Echocardiography demonstrated transposition of the great vessels with the aorta arising from the right ventricle and the pulmonary artery from the left ventricle. An atrial septal defect, ASD, was also present, allowing for some mixing of oxygenated and deoxygenated blood. Chest X-ray showed a characteristic egg on a string appearance of the cardiac silhouette. ECG displayed a normal sinus rhythm with no specific abnormalities. Management: immediate administration of prostaglandin E1, PGE1, to maintain ductal patency and allow for increased mixing of oxygenated and deoxygenated blood. The neonatology and pediatric cardiology teams were consulted for further management. A balloon atrial septostomy was performed urgently to enhance mixing at the atrial level, followed by stabilization in the neonatal intensive care unit. The patient was scheduled for an arterial switch operation within the first 2 weeks of life to correct the transposed great vessels and ensure proper oxygenation of systemic circulation. This clinical scenario is typical for a neonate with transposition of the great vessels, TGV, highlighting the urgent need for recognition and management of this congenital heart defect to prevent hypoxemic complications and ensure survival. # oral exam questions on transposition of the great vessels. Question 1. Q. What is the pathophysiology of transposition of the great vessels, TGV? In TGV, there is an anatomical reversal where the aorta arises from the right ventricle and the pulmonary artery from the left ventricle. This leads to 2 parallel circulations. Systemic deoxygenated blood recirculates through the body and oxygenated pulmonary blood recirculates through the lungs. Survival depends on mixing of oxygenated and deoxygenated blood through intracardiac shunts like ASD, VSD, or extracardiac connections, such as a patent ductus arteriosus, PDA. Question 2. How does gestational diabetes in the mother predispose to TGV in the newborn? A. Infants born to mothers with diabetes have an increased risk of developing TGV. The exact mechanism is not fully understood, but it is believed that hyperglycemia and other metabolic disturbances during pregnancy can affect fetal heart development, leading to congenital heart defects such as TGV. Question 3. What are the clinical manifestations of TGV in a newborn? Newborns with TGV typically present with cyanosis that does not improve with oxygen supplementation, tachypnea, and signs of heart failure. Diminished femoral pulses compared to brachial pulses may also be observed due to the abnormal circulation. Question 4. Q. Describe the egg on a string sign associated with TGV. A. The egg on a string sign, seen on a chest X-ray, describes the appearance of the cardiac silhouette in TGV. The egg represents the enlarged globular heart, while the string denotes the narrow superior mediastinum due to themic atrophy, which is stress-induced. Question 5. What is the role of prostaglandin E1, PGE1, in the management of TGV? In TGV, PGE1 is administered to maintain the patency of the ductus arteriosus, providing a temporary extracardiac shunt to allow some mixing of oxygenated and deoxygenated blood, thus improving systemic oxygenation until definitive surgical intervention can be performed. Question 6. What is the definitive surgical treatment for TGV and what does it involve? The definitive surgical treatment for TGV is the arterial switch operation. This procedure involves reestablishing the correct ventriculo-arterial connections by physically switching the aorta and the pulmonary artery to their appropriate ventricles. Additionally, coronary arteries are reimplanted into the neo-aorta. This surgery is usually performed within the first 2 weeks of life to ensure proper systemic oxygenation. Summary on tricuspid valve atresia. Tricuspid valve atresia overview definition: a congenital heart defect characterized by the absence or underdevelopment of the tricuspid valve, leading to no direct blood flow from the right atrium RA to the right ventricle RV. Epidemiology: it occurs in about 0.2–1.2 per 1,000 live births and is the third most common cyanotic congenital heart defect CHD. Associated cardiac defects: atrial septal defect ASD, ventricular septal defect VSD, right ventricular RV hypoplasia, possible pulmonary outflow obstruction, aortic stenosis, or coarctation. Pathophysiology: blood from the RA bypasses the atretic tricuspid valve via an ASD, mixing with oxygenated blood in the left atrium and leading to systemic cyanosis. The VSD allows for some blood flow into the hypoplastic RV and then to the lungs. Clinical features: central cyanosis within days post-birth, tachypnea, signs of heart failure, holosystolic murmur at the lower left sternal border and a single S2 heart sound, jugular venous distension with a prominent A wave due to RA overload. Diagnostics: echocardiography, confirmatory tests showing the absence of the tricuspid valve, ASD, and RV hypoplasia. Chest X-ray, mild cardiomegaly with abnormal pulmonary markings. ECG, left ventricular hypertrophy, LVH, with left axis deviation, tall P waves, and minimal R waves in the precordial leads. Pulse oximetry, decreased oxygen saturation. Initial management: stabilization with prostaglandin E1, PG1 infusion to maintain ductal patency and provide cardiopulmonary support. Surgical repair, a three-stage approach similar to the management of Hypoplastic Left Heart Syndrome, HLHS, is aimed at separating pulmonary and systemic circulations. Stage 1, palliation in the neonatal period to ensure pulmonary blood flow, e.g. Blalock-Taussig shunt. Stage 2 and 3, further surgeries to redirect systemic venous blood directly to the lungs and separate the circulations. Prognosis. With surgical intervention, the survival rate is about 90% at 1 year of age and about 80% at 10 years. Tricuspid valve atresia requires interatrial and interventricular communications for survival. The mainstay of treatment is surgical, following a staged approach to separate the circulations. Early diagnosis, typically via fetal echocardiography, and immediate postnatal management are crucial for improving outcomes. Clinical case, tricuspid valve atresia. Patient profile, age, 2 days old, sex, male, medical history, unremarkable prenatal history. The mother had regular prenatal care with no reported complications. The patient was born at term via spontaneous vaginal delivery. Presenting complaint, the patient presents with cyanosis and tachypnea noted a few hours post-birth. The cyanosis worsens during feeding and crying. Vital signs, heart rate 160 BPM, respiratory rate 60 breaths per minute, oxygen saturation 85% on room air, blood pressure 45 millimeter Hg, temperature 36.8 degrees Celsius, 98.0 Fair. Physical examination, general appearance, the infant appears cyanotic with a tinge of blue discoloration around the lips and nail beds. Cardiovascular, a single loud S2 is heard on auscultation with a holosystolic murmur at the lower left sternal border. No palpable thrills or heaves. Peripheral pulses are diminished. Respiratory, tachypneic with clear lungs on auscultation. Abdomen, soft, non-distended, no hepatomegaly palpable. Investigations, chest X-ray shows mild cardiomegaly with decreased pulmonary vascular markings. Echocardiogram, reveals absence of the tricuspid valve with a large atrial septal defect, ASD, and hypoplastic right ventricle. There is evidence of a small ventricular septal defect, VSD. ECG demonstrates left axis deviation and tall P waves, indicative of left ventricular hypertrophy and right atrial enlargement. Diagnosis. The findings are consistent with tricuspid valve atresia, categorized as a cyanotic congenital heart defect due to the absence or underdevelopment of the tricuspid valve, leading to no direct flow from the right atrium to the right ventricle. Management plan. Immediate, start prostaglandin E1, PGE1 infusion to maintain ductal patency and ensure systemic perfusion. Initiate oxygen supplementation and consider mechanical ventilation if respiratory distress worsens. Surgical intervention, plan for a staged surgical approach. Initially, a systemic to pulmonary artery shunt, e.g. modified Blalock-Taussig shunt, to ensure adequate pulmonary blood flow. Follow-up, regular monitoring in a pediatric cardiac care unit with subsequent surgeries planned as the patient grows, aiming for a complete separation of pulmonary and systemic circulations. Prognosis. With timely intervention and appropriate surgical management, the prognosis can be favorable. However, close monitoring for complications such as heart failure, arrhythmias, and growth delays is essential throughout the patient's life. Oral exam questions and answers on tricuspid valve atresia. Question 1. Describe the pathophysiology of tricuspid valve atresia. In tricuspid valve atresia, the tricuspid valve is either absent or underdeveloped, preventing blood flow from the right atrium to the right ventricle. This leads to right ventricular hypoplasia. Survival depends on the presence of interatrial and interventricular communications, such as an atrial septal defect, ASD, or a ventricular septal defect, VSD, allowing for the mixing of oxygenated and deoxygenated blood and systemic circulation of this mixed blood. Question 2. Q. What are the typical clinical features observed in a neonate with tricuspid valve atresia? Neonates with tricuspid valve atresia typically present with cyanosis, tachypnea, and signs of heart failure shortly after birth. The cyanosis is central and worsens with activities like feeding or crying. On cardiac examination, a hollow systolic murmur at the lower left sternal border and a single S2 can be noted. Peripheral pulses may be diminished due to decreased cardiac output. Question 3Q. How is tricuspid valve atresia diagnosed? Tricuspid valve atresia is diagnosed primarily through echocardiography, which can visualize the absence of the tricuspid valve, the presence of ASD and/or VSD, and right ventricular hypoplasia. Complementary diagnostic tools include chest X-ray, which may show cardiomegaly and abnormal pulmonary markings, and ECG, which might show left axis deviation and tall P waves indicative of left ventricular hypertrophy and right atrial enlargement. Question 4. What is the initial management for a neonate diagnosed with tricuspid valve atresia? Initial management includes medical stabilization with prostaglandin E1, PGE1, to maintain ductal patency and ensure systemic perfusion. Cardiorespiratory support may be necessary, including oxygen supplementation and possibly mechanical ventilation. Diuretics and inotropic agents may be used to manage heart failure symptoms. Question 5. Describe the surgical treatment approach for tricuspid valve atresia. Surgical treatment for tricuspid valve atresia involves a staged approach, beginning with palliative surgery to ensure adequate pulmonary blood flow, such as a systemic to pulmonary artery shunt, e.g. modified Blalock-Taussig shunt. Subsequent surgeries, typically done as the child grows, aim for complete separation of pulmonary and systemic circulations, ultimately leading to the Fontan procedure, which directs systemic venous blood directly to the pulmonary arteries, bypassing the right heart. These questions and answers cover the essential aspects of understanding, diagnosing, and managing tricuspid valve atresia, highlighting the importance of early diagnosis and intervention to improve outcomes. Ebstein anomaly is a rare congenital heart defect characterized by malformation and apical displacement of the tricuspid valve leaflets into the right ventricle, leading to tricuspid regurgitation and enlargement of the right side of the heart. This condition can also involve interatrial communication, such as a patent foramen ovale, PFO, or atrial septal defect, ASD, and is often associated with arrhythmias like Wolff-Parkinson-White syndrome. The clinical presentation varies from asymptomatic individuals to those experiencing cyanosis, heart failure, or arrhythmias, depending on the severity of the tricuspid valve displacement and regurgitation. Summary for professional specialists. Diagnostic findings. Echocardiography, confirmation of an enlarged right heart, tricuspid regurgitation, and displacement of tricuspid valve leaflets. Chest X-ray may show varying degrees of cardiomegaly and right atrial enlargement. MRI, visualization of apical displacement of septal and posterior tricuspid leaflets. ECG, potential findings include tall and broad P waves, first-degree atrioventricular block, right axis deviation, and right bundle branch block. Look for delta waves indicative of Wolff-Parkinson-White syndrome. Pulse oximetry, reduced oxygen saturation indicating cyanosis in severe cases. Treatment options. Initial management, stabilization with PGE1 infusion to maintain ductal patency, alongside inhaled nitric oxide or milrinone infusion to decrease pulmonary vascular resistance, PVR, and improve oxygenation. Surgical repair, goals include systemic pulmonary shunt creation, tricuspid valve repair, and right ventricle reconstruction. The timing and approach depend on the patient's age and the severity of symptoms. Arrhythmia management. Catheter ablation may be necessary for patients with significant arrhythmias like Wolff-Parkinson-White syndrome. Drugs and classes, prostaglandins, alprostadil, PGE1 for ductal patency, inotropes, digoxin for heart failure symptoms, enhancing myocardial contractility. Diuretics, loop diuretics like furosemide to manage fluid overload in heart failure. Arrhythmia management, antiarrhythmic drugs as indicated by specific arrhythmic conditions with catheter ablation as a potential intervention for refractory cases. Prognosis. The prognosis of Ebstein anomaly varies widely, with about 30% mortality in the first year of life without intervention. The long-term outlook depends on the success of surgical interventions, the management of heart failure and arrhythmias, and the degree of tricuspidal regurgitation and right heart enlargement. High yield points for exams. Ebstein anomaly is characterized by the apical displacement of the tricuspid valve into the right ventricle. It is often associated with ASD-PFO and arrhythmias like Wolff-Parkinson-White syndrome. Management includes medical stabilization, with surgical repair being definitive treatment. Prognosis is variable and depends on the severity of the defect and associated conditions. Clinical case, Ebstein anomaly. Patient information, age, 16 years old, gender, female. Presenting complaint, episodes of palpitations and shortness of breath, especially during physical activity. History, the patient reports experiencing palpitations that she describes as a racing heart, accompanied by shortness of breath during her physical education class at school. These episodes have become more frequent over the past 6 months. She also mentions occasional episodes of fatigue and a noticeable decrease in exercise tolerance. Physical examination, general appearance, well-nourished female in no acute distress. Vital signs, blood pressure 110 70 millimeter Hg, heart rate 92 BPM, respiratory rate 18 breaths per min, oxygen saturation 97% on room air. Cardiovascular examination, auscultation reveals a loud first heart sound S1 and a widely split second heart sound S2 with no evidence of murmur at rest. An occasional irregular heartbeat is noted. No jugular venous distension or peripheral edema is observed. Diagnostic workup, echocardiography, reveals apical displacement of septal and posterior leaflets of the tricuspid valve, significant atrialization of the right ventricle, and mild tricuspid regurgitation. Electrocardiogram, ECG, demonstrates first-degree atrioventricular block and occasional premature atrial contractions. Evidence of right atrial enlargement is also noted. Chest X-ray shows mild cardiomegaly with prominence of the right heart border. Exercise stress test. Patient develops supraventricular tachycardia during moderate exercise, correlating with her symptoms of palpitations. Diagnosis. The findings are consistent with Ebstein anomaly, with associated arrhythmia likely contributing to the patient's symptoms. Treatment plan. Medical management, initiated with beta blockers to manage supraventricular tachycardia and improve exercise tolerance. Surgical consultation, referral to a pediatric cardiologist for evaluation of potential surgical intervention given the patient's symptoms and the echocardiographic findings. Arrhythmia management, further evaluation with a 24-hour Holter monitor to assess the frequency and type of arrhythmias, with consideration of electrophysiological study and potential catheter ablation for refractory arrhythmia. Follow-up, regular cardiology follow-up to monitor the progression of tricuspid regurgitation and right heart size, with echocardiography scheduled every 6 to 12 months. Discussion points for teaching. Importance of recognizing variable presentations of Ebstein anomaly from asymptomatic to heart failure and significant arrhythmias. The role of imaging in diagnosing structural heart defects and guiding treatment planning. Management strategies for associated arrhythmias in congenital heart disease, including pharmacological and interventional approaches. Oral exam questions and answers on Ebstein anomaly. Question 1. What are the diagnostic criteria for Ebstein anomaly on echocardiography? A. The diagnostic criteria for Ebstein anomaly on echocardiography include apical displacement of the septal and posterior leaflets of the tricuspid valve, atrialization of the right ventricle, and tricuspid regurgitation. Additional findings may include right atrial enlargement and interatrial communication, such as an atrial septal defect or patent foramen ovale. Question 2. Q. How do the clinical manifestations of Ebstein anomaly vary with age? A. Clinical manifestations of Ebstein anomaly can range from asymptomatic to severe, depending on the anomaly's severity. Neonates may present with cyanosis, heart failure, and respiratory distress. Adolescents and adults often present with arrhythmias like supraventricular tachycardia or Wolff-Parkinson-White syndrome, exercise intolerance, and palpitations. The severity of tricuspid regurgitation and right ventricular impairment often dictates the clinical presentation. Question 3. Q. What is the role of surgical intervention in the management of Ebstein anomaly? A. Surgical intervention in Ebstein anomaly aims to correct tricuspid valve malformations, reduce the size of the atrialized right ventricle, and address any associated cardiac defects like atrial septal defects. The timing and type of surgery depend on the severity of the anomaly, the presence of symptoms, and the patient's overall health. Surgical options include tricuspid valve repair or replacement, and in some cases, a bidirectional Glenn or Fontan procedure for patients with significant right ventricular dysfunction. Question 4. Explain the association between Ebstein anomaly and arrhythmias. Ebstein anomaly is commonly associated with arrhythmias due to the displacement of the tricuspid valve and the enlargement of the right atrium, which can disrupt normal electrical pathways and lead to reentrant tachycardias. The most common associated arrhythmia is Wolff-Parkinson-White, WPW syndrome, where an accessory conduction pathway leads to episodes of supraventricular tachycardia. Q. How does Ebstein anomaly affect the presentation of heart sounds on physical examination? In Ebstein anomaly, the first heart sound, S1, is usually loud due to the delayed closure of the malformed tricuspid valve. There can also be a widely split S1, S2 due to the delayed electrical activation and contraction of the right ventricle. A holosystolic murmur may be present at the left lower sternal border due to tricuspid regurgitation. Summary on total anomalous pulmonary venous return, TAP-VR. Definition and pathophysiology. TAP-VR is a congenital heart defect where all pulmonary veins drain into the systemic venous circulation rather than the left atrium. This condition often coexists with an atrial septal defect, ASD, or a patent ductus arteriosus, PDA, to allow for the mixing of oxygenated and deoxygenated blood. The clinical severity depends on the degree of pulmonary venous obstruction and the extent of venous mixing, leading to cyanosis, respiratory failure, and right ventricular hypertrophy, RVH. Epidemiology and etiology. It occurs in approximately 0.6 to 1.2 per 10,000 live births. The etiology is multifactorial, with associations to genetic alterations and heterotaxy syndromes, particularly those involving asplenia. Clinical features: newborns present with cyanosis, respiratory distress, poor feeding, failure to thrive, and hepatomegaly. Cardiac examination might reveal a fixed split S2 or loud S2 and a systolic ejection murmur with or without a diastolic rumble. Diagnostic findings. Echocardiography confirms the diagnosis by showing the abnormal pulmonary venous connection and right heart enlargement. Chest X-ray may show the snowman sign in supracardiac TAP-PVR, indicative of the anomalous venous drainage and right heart enlargement. ECG generally shows nonspecific findings but may include signs of RVH. Pulse oximetry demonstrates reduced oxygen saturation. Treatment. Immediate postnatal management focuses on stabilizing the infant with mechanical ventilation, supplemental oxygen, and inotropes as needed. Surgical repair, necessary for all patients, regardless of disease severity, to correct the anomalous venous drainage and prevent long-term complications. Prognosis. Surgical correction significantly improves long-term survival rates to 80 to 90%. Without intervention, the mortality rate within the first year of life is approximately 80%. Medications and specific interventions. Presurgical stabilization might include the use of prostaglandins to maintain ductal patency in cases with associated cardiac defects that rely on ductal-dependent circulation. Surgical options are tailored to the type of TAP-VR and the presence of associated defects, focusing on reestablishing the correct pulmonary venous drainage into the left atrium. This concise summary provides a high-yield overview suitable for professionals and students in the medical and dental fields, emphasizing pathophysiology, clinical presentation, diagnostic approach, and management principles for TAP-VR. Clinical case. Total anomalous pulmonary venous return, TAP-VR. Patient profile. Age, 3 weeks old, sex, male, medical history, unremarkable prenatal history. The patient was born full term via normal vaginal delivery. The mother had routine prenatal care without any significant findings. Presenting complaint. The infant was brought to the emergency department by his parents due to episodes of cyanosis, especially during feeding, and a noticeable decrease in feeding volume over the past week. Clinical examination. General appearance. The infant appears cyanotic, especially around the lips and fingertips, and is mildly tachypneic at rest. Vital signs. Tachycardia, HR 168 BPM, respiratory rate increased, RR 60 breaths min, SpO2 85% on room air. Cardiovascular examination. A fixed split-second heart sound, S2, was noted, with a soft systolic murmur audible at the left upper sternal border. No diastolic murmurs were detected. Peripheral pulses were palpable but weak. Investigations. Chest X-ray. Demonstrated cardiomegaly with a snowman sign suggestive of supracardiac TAP-VR and increased pulmonary vascular markings. Echocardiography. Confirmed the diagnosis of TAP-PVR with all pulmonary veins draining into a common chamber that connected anomalously to the superior vena cava, SVC. An associated atrial septal defect, ASD, allowed for right-to-left shunting. ECG showed right axis deviation and signs of right ventricular hypertrophy. Management. The infant was immediately placed on supplemental oxygen, which marginally improved SpO2 to 88%. Prostaglandin E1 was administered to maintain ductal patency and ensure systemic circulation. The infant was stabilized and prepared for surgical intervention with a planned approach to reroute the pulmonary venous return to the left atrium and close the ASD. Surgical outcome. The surgical repair was successful, with postoperative echocardiography confirming proper routing of pulmonary veins to the left atrium and closure of the ASD. The infant's recovery was closely monitored in the pediatric cardiac intensive care unit, with gradual improvement in oxygen saturation and overall clinical condition. Follow-up. The infant was discharged 2 weeks post-surgery, with scheduled follow-up appointments in the pediatric cardiology clinic. The focus of follow-up care included monitoring cardiac function, growth and development assessment, and early detection of potential post-operative complications. This clinical case illustrates the presentation, diagnosis, and management of TAP-VR, emphasizing the critical need for early recognition and surgical intervention in affected neonates. Oral exam questions on total anomalous pulmonary venous return, TAP-VR, and answers. Question 1. Describe the pathophysiology of total anomalous pulmonary venous return, TAP-VR. In TAP-VR, all pulmonary veins drain abnormally into the systemic venous circulation instead of the left atrium. This results in the mixing of oxygenated pulmonary venous blood with deoxygenated systemic venous blood, leading to systemic arterial desaturation and cyanosis. The condition often necessitates an atrial level shunt, like an atrial septal defect, ASD, for survival, allowing some oxygenated blood to enter the systemic circulation. Question 2. What are the clinical manifestations of TAP-VR in a neonate? A. Neonates with TAP-VR often present with cyanosis, respiratory distress, difficulty feeding, and failure to thrive. Cyanosis might not improve with oxygen administration due to the inherent mixing of oxygenated and deoxygenated blood at the atrial level. Question 3. How is TAP-VR diagnosed? A. TAP VR is diagnosed primarily through echocardiography, which can visualize the anomalous pulmonary venous drainage and associated cardiac defects like ASD. Chest X-ray may show a snowman or figure of 8 sign in supracardiac TAP VR and increased pulmonary vascular markings due to pulmonary venous congestion. Question 4. What is the definitive treatment for TAP VR? Surgical repair is the definitive treatment for TAP VR and is recommended for all patients regardless of the type. The surgery involves rerouting the pulmonary veins to the left atrium and closing any associated intracardiac shunts, such as an ASD. Question 5. How does the snowman sign appear on a chest X-ray in the context of TAP VR, and what does it signify? A. The snowman sign appears in supracardiac TAP VR and is characterized by a supracardiac shadow that represents the dilated vertical vein, the innominate vein, and the superior vena cava, forming the head of the snowman, while the heart forms the base. This sign signifies the presence of a supracardiac anomalous pulmonary venous connection and is associated with pulmonary venous congestion. These questions cover the essential aspects of TAP VR, from pathophysiology and clinical presentation to diagnosis and treatment, offering a comprehensive overview suitable for an oral exam setting. Summary of persistent truncus arteriosus for medical professionals. Persistent truncus arteriosus, PTA, overview. PTA is characterized by the failure of the aorticopulmonary septum to divide the truncus arteriosus into separate aortic and pulmonary trunks. This results in a single arterial trunk emerging from the heart, serving both systemic and pulmonary circulations. Associated cardiac defects. Ventricular septal defect, VSD, potential for an interrupted aortic arch. Coronary artery anomalies. Epidemiology. Occurs in approximately 1 out of 10,000 live births, often associated with DiGeorge syndrome. Etiology. Incomplete formation of the aorticopulmonary septum due to disrupted neural crest cell migration. Pathophysiology. Mixed oxygenated and deoxygenated blood due to VSD. The single arterial trunk handles output from both ventricles, leading to systemic and pulmonary circulation mixing. Clinical features: cyanosis and respiratory distress, failure to thrive in infants, bounding peripheral pulses, and harsh systolic murmur at the lower left sternal border. Diagnostic tools: echocardiography confirms single arterial trunk and associated defects like VSD. Chest X-ray may show a right-sided aortic arch and increased pulmonary vascular markings. ECG and pulse oximetry often show nonspecific findings, decreased oxygen saturation. Treatment: initial medical management, stabilization with diuretics, inotropic support, e.g. dopamine, ventilation, and correction of metabolic acidosis. Surgical repair recommended in the neonatal period to correct the truncal valve and close the VSD, ensuring proper separation of systemic and pulmonary circulations. Prognosis: post-surgical repair, the 30-year survival rate is around 70%. Medications: diuretics, e.g. furosemide, to manage symptoms of heart failure, inotropes, dopamine for hemodynamic support, prostaglandins, e.g. prostaglandin E1, to maintain ductal patency preoperatively in certain cases. This summary provides a comprehensive overview tailored for medical and dental professionals, focusing on essential diagnostics, clinical presentation, and the specific treatment approaches for persistent truncus arteriosus, including relevant medications. Clinical case: persistent truncus arteriosus. Patient profile, age 3 weeks, gender female. Medical history, normal vaginal delivery at term, unremarkable prenatal history. Presenting complaint. Parents report rapid breathing, poor feeding, and mild cyanosis, especially during breastfeeding. History of present illness. Over the past week, the infant has shown signs of difficulty feeding with frequent pauses to breathe. The parents also noticed episodes of bluish discoloration around the baby's lips during these feeding sessions. Physical examination. General. The baby appears slightly underweight for her age, with peripheral cyanosis noted. Cardiovascular. There's a palpable thrill at the left sternal border and a loud, continuous murmur heard across the precordium. Peripheral pulses are bounding. Respiratory, tachypnea, and mild subcostal retractions noted without additional respiratory distress at rest. Abdomen, soft, non-distended, no hepatomegaly palpable. Diagnostic findings, pulse oximetry, oxygen saturation of 92% on room air. ECG, biventricular hypertrophy with signs of volume overload. Chest X-ray, cardiomegaly with increased pulmonary vascular markings and a right-sided aortic arch. Echocardiography demonstrates a single great vessel arising from the base of the heart, supplying systemic, coronary, and pulmonary circulations consistent with PTA. A ventricular septal defect, VSD, is also present. Clinical course. The infant was immediately started on diuretics to manage symptoms of heart failure and supplemental oxygen to improve oxygenation. Given the diagnosis of PTA, surgical intervention was deemed urgent. The cardiology team performed a surgical repair which involved separating the pulmonary arteries from the common arterial trunk and closing the VSD, redirecting the blood flow correctly. Post-surgery, the infant showed significant improvement in symptoms with no episodes of cyanosis. Feeding tolerance improved remarkably. Follow-up. The infant was discharged with close follow-up appointments in the pediatric cardiology clinic. Medications for heart failure were gradually tapered based on the clinical response. Long-term follow-up will focus on monitoring heart function, growth and development, and timely intervention for potential postoperative complications such as pulmonary hypertension or residual VSDs. This case illustrates a typical presentation and management strategy for an infant diagnosed with persistent Truncus Arteriosus, underscoring the importance of early detection, prompt surgical correction, and the complexities involved in postoperative care. Cached oral exam questions and answers on persistent Truncus Arteriosus, PTA. Question 1. What is the hallmark feature of persistent Truncus Arteriosus on echocardiography? The hallmark feature of PTA on echocardiography is the presence of a single arterial trunk arising from the base of the heart that overrides a ventricular septal defect, VSD, giving rise to the systemic, coronary, and pulmonary circulations. Question 2. Q. Explain why patients with persistent Truncus Arteriosus exhibit signs of heart failure early in life. A. Patients with PTA exhibit signs of heart failure early in life due to the mixing of oxygenated and deoxygenated blood through the VSD and the single common arterial trunk, leading to volume and pressure overload in the heart. This overload increases the work of the heart and can quickly lead to heart failure symptoms. Question 3. Q. What is the significance of the right-sided aortic arch in patients with PTA? A. A right-sided aortic arch is a common associated finding in patients with PTA and can have surgical implications. It is indicative of the abnormal development of the aortic arch system and is often associated with other congenital heart defects. It's important for surgical planning and postoperative management. Question 4. Why is surgical intervention urgent in newborns diagnosed with PTA? A. Surgical intervention is urgent in PTA to correct the abnormal circulation, separate the pulmonary and systemic circulations, and close the VSD. This is crucial to prevent complications such as severe heart failure, irreversible pulmonary hypertension, and to improve the survival and quality of life of the patient. Question 5. Describe the typical postoperative management for a patient with PTA. A. Postoperative management typically involves close monitoring for signs of heart failure, arrhythmias, and pulmonary hypertension. Management may include medications such as diuretics to manage fluid overload, inotropic agents to support heart function, and possibly oxygen therapy. Long-term follow-up with a pediatric cardiologist is essential to monitor heart function and detect any residual or recurrent issues. These questions and answers cover the essential aspects of understanding, diagnosing, and managing persistent Truncus Arteriosus, reflecting the depth of knowledge required for medical professionals dealing with congenital heart defects. Summary: Hypoplastic Left Heart Syndrome, HLHS. Definition and epidemiology. HLHS is a severe congenital defect characterized by underdevelopment of the left side of the heart. It's rare, with an incidence of 2 to 3 per 10,000 live births in the US and more common in males. Etiology. The cause is multifactorial, involving genetic polymorphisms, altered fetal blood flow, and possibly intrauterine infections. It's associated with chromosomal anomalies like trisomy 13, 18, Turner syndrome, and Jacobson syndrome. Pathophysiology. The left ventricle is severely underdeveloped, rendering it non-functional. Survival relies on right-to-left shunting through a patent ductus arteriosus, PDA, and an atrial septal defect, ASD. Clinical presentation. Symptoms might not be present at birth if the PDA allows adequate systemic perfusion. Symptoms, including cyanosis, rapid breathing, low blood pressure, and signs of heart failure, worsen as the PDA closes. Diagnostic findings. Echocardiography is confirmatory, showing a small or absent left ventricle and other associated defects. ECG is generally normal. Chest X-ray findings are nonspecific, and pulse oximetry shows reduced oxygen saturation. Treatment. Initial management involves continuous infusion of prostaglandin E1 to keep the PDA open. Surgical intervention is necessary and involves a 3-stage procedure. Norwood procedure. Stage 1. Constructs a new aortic outlet from the right ventricle and connects the pulmonary artery to the systemic circulation. Glenn procedure. Stage 2. Redirects superior vena cava blood flow directly to the lungs, bypassing the heart. Fontan procedure, stage 3, connects the inferior vena cava to the pulmonary circulation, completing the separation of pulmonary and systemic circulations. Heart transplantation is an alternative for patients who cannot undergo or fail the staged surgeries. Prognosis. Despite surgical treatment, the 5-year survival rate remains modest. Long-term survival into adolescence is possible for those who survive the first year post-surgery, but lifelong cardiac care is necessary. This summary provides a concise overview of HLHS, emphasizing critical aspects like pathophysiology, diagnostics, and treatment strategies, crucial for professional medical education and clinical practice in pediatric cardiology. Clinical case: Hypoplastic Left Heart Syndrome, HLHS. Patient profile: age, newborn, 2 days old, gender, male. Prenatal history: maternal reports were unremarkable, no significant findings on routine prenatal ultrasounds. Presenting complaint: the nursing staff observed increasing cyanosis and respiratory distress in the neonate, especially when crying. History of present illness: the infant was born at term via spontaneous vaginal delivery without complications. Initial APGAR scores were 8 and 9 at 1 and 5 minutes, respectively. The baby was noted to have mild cyanosis at birth, which initially improved with oxygen. Over the first 48 hours of life, the infant developed increasing difficulty with feeding, marked tachypnea, and worsening cyanosis. Physical examination: general, mild cyanosis, more pronounced in the perioral area and extremities. The infant appears lethargic. Cardiovascular: the heart rate is tachycardic, pulses are diminished in all extremities. There is no murmur, but a loud single S2 is audible. No peripheral edema is noted. Respiratory: tachypnea with subcostal retractions. Lung fields are clear on auscultation. Abdomen: soft, non-distended, no hepatosplenomegaly. Extremities: cool to touch with prolonged capillary refill time. Diagnostic workup: pulse oximetry shows oxygen saturation of 75% on room air. Chest X-ray reveals a normal-sized cardiac silhouette with decreased pulmonary vascular markings. ECG shows right axis deviation and right ventricular hypertrophy. Echocardiography confirms the diagnosis of HLHS, showing a severely hypoplastic left ventricle, atresia of the mitral and aortic valves, and a large patent ductus arteriosus providing systemic circulation. Clinical course. The neonate was immediately started on prostaglandin E1 to maintain ductal patency and provide systemic circulation. Due to the critical nature of the condition, the pediatric cardiology team was consulted, and the decision was made to proceed with the Norwood procedure as soon as the infant was stabilized. The infant underwent the Norwood procedure on day 5 of life. The postoperative course was closely monitored in the pediatric cardiac ICU, with careful attention to hemodynamic status and organ perfusion. Follow-up. The infant demonstrated gradual improvement postoperatively, with better oxygen saturation levels and reduced respiratory distress. Discharge from the hospital with close outpatient follow-up planned with pediatric cardiology, including scheduled echocardiograms to monitor progress and plan for the next stages of surgical palliation. Discussion. This case illustrates a typical presentation and management pathway for a neonate with HLHS, emphasizing the critical role of early recognition, medical management to maintain ductal patency, and timely surgical intervention in the management of this complex congenital heart defect. Oral exam questions and answers on Hypoplastic Left Heart Syndrome, HLHS. Question 1. Describe the pathophysiology of Hypoplastic Left Heart Syndrome, HLHS. In HLHS, there's underdevelopment of the left-sided heart structures, including a severely hypoplastic left ventricle, often combined with atresia or severe stenosis of the mitral and/or aortic valves. This leads to inadequate systemic circulation, as the left ventricle is unable to effectively pump blood to the body. Survival depends on right-to-left shunting of blood through a patent ductus arteriosus and an atrial septal defect to provide systemic circulation. Question 2. What are the clinical manifestations of HLHS in a neonate? Neonates with HLHS typically present with cyanosis, respiratory distress, and signs of poor perfusion such as weak pulses and cool extremities. Symptoms often worsen as the ductus arteriosus begins to close, leading to decreased systemic blood flow. How is HLHS diagnosed? The diagnosis of HLHS is often made prenatally via fetal echocardiography. Postnatally, it is confirmed with echocardiography demonstrating the characteristic findings of a hypoplastic left ventricle and atresia or severe stenosis of the mitral and aortic valves. Additional findings may include an enlarged right ventricle, a patent ductus arteriosus, and an atrial septal defect. Question 4. What is the initial management for a neonate diagnosed with HLHS? Initial management includes medical stabilization with prostaglandin E1 to maintain patency of the ductus arteriosus, ensuring systemic circulation. Supportive care for heart failure symptoms, such as inotropes and diuretics, may also be necessary. Question 5. Describe the surgical management strategy for HLHS. A. The surgical management of HLHS involves a series of palliative surgeries. The first stage is the Norwood procedure, typically performed soon after birth, which reconstructs the aorta and connects the right ventricle to the systemic circulation. The second stage, the Glenn procedure, is usually performed at 3 to 6 months of age and involves connecting the superior vena cava to the pulmonary arteries. The final stage, the Fontan procedure, completed at 2 to 4 years of age, connects the inferior vena cava to the pulmonary arteries, allowing for passive blood flow to the lungs. These questions encapsulate the critical aspects of understanding, diagnosing, and managing HLHS, which is vital knowledge for professionals dealing with pediatric cardiology cases.